Great. Well, good morning, everyone. Thank you so much for joining us today for this very special webinar. Today's session is being hosted by Royal Columbian Hospital Foundation, and my name is Linda Morgan. I am privileged to be part of the team here at the Foundation, and the Foundation exists to build public support to advance the mission of Royal Columbian Hospital. Royal Columbian Hospital is the only hospital in the province with cardiac, trauma, neurosciences, high-risk maternity, and neonatal intensive care all on one site, which means that RCH sees 1 in 3 people across BC for critical care. Before we dive into this very important topic, I'd like to begin by acknowledging that Royal Columbian Hospital and the Foundation are located on the traditional, ancestral, and unceded shared territories of the Kwantlen and Kikite First Nations, and home to the North Fraser Métis Association. On a personal note, my family moved to this area in 2021, and I am grateful to live, work, and play on this land. Now, let's move on to our main event. It's not every day that we get to talk about something as remarkable as the piece of equipment that you see on your screen. The Ventana Benchmark Ultra is a laboratory analyzer that we are going to learn all about today. This equipment, together with the expertise of Royal Columbian Hospital staff, is going to revolutionize how we help breast cancer patients across Fraser Health. Thanks to the incredible generosity of our donors, this cutting-edge technology is now part of our hospital's toolkit in our vision to provide the best care for our patients. I want to take a moment to express our heartfelt gratitude to the donors who made this possible. Drive for the Cure Foundation and Sanjeev Garg and Seema Garg. Your support, dedication, and belief in our cause have taken us a step closer to transforming lives. We also wouldn't be here today without the expertise and dedication of our wonderful panelists. So let me introduce them to you. First up will be Dr. Carolyn Shiau. Dr. Shiau is a versatile medical professional who transitioned from an anatomic pathologist to regional medical director for Fraser Health Laboratory in October 2021. She's a clinical associate professor at the University of British Columbia, actively involved in medical education, and has been a pioneer in the Fraser Health Physician Quality Improvement Program. With a Master of Science in Quality Improvement and Patient Safety from the University of Toronto, she is a strong advocate for patient-centered care and provided invaluable guidance at the COVID-19 Vaccine Coordination Center. Outside of work, she's an active member of the Phoenix Chamber Choir and enjoys hiking and cycling in her local area. Next, I am honored to introduce Dr. Sidhu. Originally from Nova Scotia, Dr. Sidhu obtained her Bachelor of Science at St. Mary's University, and she pursued her medical degree and general surgery residency at the University of Saskatchewan. She expanded her expertise with a fellowship in trauma surgery at the University of British Columbia. For the last 10 years, she's been a staff surgeon at Royal Columbian and Eagle Ridge Hospitals. Notably, at Royal Columbian, Dr. Sidhu is part of a pioneering breast surgery team, making the hospital the first in British Columbia to offer radio-seed localization for breast lesions. Her dedication to providing diverse surgical options, including immediate reconstruction for mastectomy patients, has left a significant mark in the field of breast cancer surgery. And to round out the patient journey, we have Dr. Simon Yu as our third panelist. Dr. Yu is a medical oncologist at Burnaby General Hospital and Ridge Meadows Hospital. He completed his medical school and internal medicine residency at University of British Columbia and completed a medical oncology fellowship at British Columbia Cancer Agency. He is a clinical instructor with the UBC Department of Medicine. I am so incredibly excited to have this exceptional trio of experts with us today, and I can't wait for you all to hear their insights and how this new equipment will provide breast cancer diagnosis and treatment. Please note that the Q&A function has been enabled, so you may type in your questions during the discussion, and we will have a time to address questions a little bit later. So thank you all for being here with us, and I know how excited you are to talk and to learn about this new technology for our region. So let's dive right into our discussion. Dr. Shiau, to help set the stage for how this machine is going to help expedite a patient's journey from diagnosis to treatment, would you please describe the initial steps of the patient journey from the discovery of a breast lump to having a biopsy performed? And how will this new technology change this experience for patients?
Thanks, Linda. I hope everyone can hear me okay. So thank you for that lovely introduction and for hosting this informational setting. Um, I think a breast cancer patient's journey is different for everyone and similar in some ways also for everyone. If you are in a screening program and you get a screening mammogram through one of our excellent radiology departments and you get recalled saying that something was found on your mammogram, you then show up to get a sample taken of what they see. And so during that procedure, you often visit a radiology department and you have a sample of tissue taken from that lesion, and that is sent to a pathology department. And the pathology department, which is where I work, is often hidden in the background and nobody knows where we are and nobody knows we exist, and we hide away in the background, and it's our job to look at that tissue and figure out, is it cancer, is it not cancer, and if it is cancer, what sorts of flags does your cancer wear that will allow us to figure out what is the best treatment or what will be the next best steps for you. So those flags are things we call tumor biomarkers, and that is becoming an increasingly important part of how we diagnose cancer today. So in our pathology department, there are three major tumor biomarkers that we care about. One is estrogen receptor, the second is progesterone receptor, and the third one is HER2. Estrogen receptor and progesterone receptor, you might be familiar with those terms. Those sound like hormones. They are hormones, and they are the markers that may be on your cancer cells that may indicate your cancer cell responds to those hormones. HER2 is a very special, different marker. It lives on the outside of cancer cells, and it is a flag that we can target if your cancer cell happens to have it. So one of the tests that we do in pathology is trying to figure out, does your breast cancer cell have HER2 on the outside as a flag? And if it does have HER2, it may mean different things for your treatment or your surgery or next steps. So this analyzer in particular is dedicated to helping us figure out that answer. Does your cancer cell express HER2? And having that analyzer within Fraser Health and able to perform it using this new technology called HER2 dual chromogenic in situ hybridization. Okay, that's a mouthful. So we call it CISH for short. By being able to do HER2 CISH here in Fraser Health, we're able to give all of the information to our clinicians upfront on your very first report, which allows us to expedite care as you move through your patient journey. So what I'm most excited about is the ability to be able to give all of that information upfront for all breast cancer patients as much as we can in Fraser Health as we move forward based on the generous donation for this analyzer to be at the Royal Columbian.
Absolutely, I share that excitement with you, Dr. Sidhu. It's truly Dr. Shiau. It's truly remarkable, and it's incredible to see how technology is just making such a profound impact on that diagnostic process and potentially reducing anxiety and wait times for patients. And I hope that our viewers will appreciate knowing sort of that human side of this advancement and how it truly translates into better care. So now let's turn our attention to the surgical aspect of breast cancer. Dr. Sidhu, at this point of the patient journey when you were brought in, can you describe sort of what happens for that patient when they are referred to a breast surgeon such as yourself?
Hi, thanks again for having me today. I'm excited about this technology as well. It's going to really help make things a lot faster and simpler for our patients. So normally I will step in as the breast surgeon where I'll get a referral from the patient's family doctor. So usually by the time a patient has been referred to me, they have already had their imaging and the sampling done of the tissue to show that they have breast cancer. So my office will receive a referral along with those imaging reports and the pathology report. When my assistant at the office sees that, it's immediately flagged, and then I would review the chart, usually even before meeting the patient. And there are certain things that I'm looking for on that chart to have an idea of what the tentative plan could be. And so one of the things that I need to try to figure out whenever I get one of these breast cancer referrals is this going to be a patient that I'm going to be doing an operation on right away? Or is this a patient that might need to see someone like Dr. Yu, one of our medical oncologists, first? And so I try my best to triage people even before I've met them, so that they will get that expedited care that they need. And the things that go into that decision have to do with often the size of the breast cancer, as well as these different receptors that Dr. Shiau has just explained. And so there are certain cancers that if they're larger or have the HER2 test as positive, those patients might be better off getting treatment with the oncologist before they get the surgery. And so I find that patients really appreciate being given all that information right at the very first visit. That's what they're hoping to get, right? They're hoping to come and see me and get answers as to what to expect, right? So unfortunately, the way things have been where that test result is a bit slow sometimes to come in, I will end up meeting the patient and let them know these are the possibilities, but we're waiting on this test result, and then I'll let you know whether or not you'll be getting surgery first. That can certainly lead to some anxiety if somebody does fall into that category where we are really dependent on that test to know what the next best step is. So having all that information right away is extremely helpful. Then I'm able to sometimes meet people on that very first visit and say, I've already spoken to our oncologist. We've made a planned decision as a team for you. In your case, you'll be getting, chemotherapy first and then be coming back to me, or vice versa. And people really appreciate that, right? Because it's a very anxiety-driven time, and patients really just want to have like a plan and answers and options right away.
Thank you. Thank you so much for sharing that, Dr. Sidhu. Thank you for sharing, and it's really inspiring to just sort of hear how this technology is enhancing that surgical aspect of breast cancer treatment, and that potential benefit for patients is really remarkable. Let's shift our focus now to the post-surgical phase with Dr. Yu. Welcome, Dr. Yu. Would you describe what happens for a patient when they are referred to a medical oncologist such as yourself?
Hi, everyone. I hope you guys can hear me okay. Quick thumbs up. Thank you. Sorry for the technical glitches from me logging on. So I echo everything that has been said so far. For patients that come to see a medical oncologist, usually they are here for a discussion with regards to what additional therapies they're eligible for or could benefit from in addition to surgery. And sometimes those discussions should happen before surgery, and sometimes those discussions should happen after surgery, depending on the nature of the breast cancer and the type of it. But a lot of times that decision needs to be made, well in advance. So I echo Dr. Sidhu's comments about how for a lot of our breast cancer patients, the best option to do is not necessarily to go to surgery right away. It is better to have systemic therapy, typically chemotherapy first, because we know that lends to better outcome. But a very important piece in trying to have that make that decision is timely access to all the necessary, what we call biomarkers, or basically characteristics of the cancer that are vital to allow us to deliver the best care possible. So having that information in a timely manner is very important.
Yes, thank you. Absolutely. It's a very patient-centered approach, Dr. Yu, and it's reassuring to know that the technology is not just improving the diagnosis and surgery, but also that overall treatment journey as well. So, we have 3 unique areas of expertise represented on our panel today, and we know that there are many other physicians from different fields of medicine who are needed to work together to help cancer patients move through the health system. Can you speak to the importance of that collaboration? Perhaps Dr. Yu, Dr. Sidhu?
Yeah, there is a lot of collaboration that definitely happens in order to create care plans where everyone is working together for the patient's best interest. And so one of the ways we collaborate is just to reach out directly to each other, right? When I'm, for example, triaging the patients and I see, okay, this might be somebody who should get chemotherapy first, I would then call one of the oncologists, perhaps speak to them directly. Sometimes each case is different, right? And sometimes the plan is not obvious what we should be doing right away, and it requires even more collaboration. And so we have regular breast rounds that we do at Royal Columbian Hospital as well as the oncology team have regular oncology rounds, and those are widely attended by the breast surgeons, the breast radiologists, who are big members of our team that we rely on heavily to plan the surgery. The pathology team that goes over the findings under the microscope, as well as both medical oncologists like Dr. Yu and radiation oncologists are all involved in creating a plan for each of our breast cancer patients.
Anything to add, Dr. Yu, on the collaboration that you see in daily?
Yeah, I agree. I think we all agree that the care plan for each patient should be highly individualized, and there are a lot of different specialties at play. We've mentioned pathology, there's radiology, there's a surgeon, there's a medical oncologist, there's often a radiation oncologist involved, sometimes a plastic surgeon as well, depending on whether reconstruction is deemed to be appropriate or necessary. So yes, there are a lot of factors involved, and sometimes it's the best way is the good old-fashioned meet in the hallway and just kind of chatting over a patient, or picking up the phone and calling somebody. There are what we call multidisciplinary rounds, where different specialties all come together and discuss perhaps potentially more challenging cases, cases that are a little unusual, and we just have that forum to pool together the expertise from really sometimes across all of Lower Mainland to try to come up with the best care plan. So those meetings happen regularly on a weekly basis as well, and I think we all learn and enrich ourselves with these collaborations. We all learn from each other, and the ultimate goal is to deliver the best possible care for each patient. So I think we do that certainly on a regular basis.
That's wonderful. Thank you. And I can definitely attest to that celebration of all of the different strengths across the region, and just with that quest to provide the best in healthcare for all of our patients. Definitely. Dr. Shiau, the analyzer has been provided to Royal Columbian Hospital by our donors. And given that the HER2-CISH analyzer technology is a relatively new addition to breast cancer diagnosis in BC, how has Royal Columbian Hospital prepared to implement and excel in utilizing this technology?
That's a great question. So to understand why has this landed at the Royal Columbian and perhaps not at another hospital at this time is a multifactorial decision that is often not within anyone's control. And so one of those main reasons is really this partnership between our hospital clinicians and the foundation. And I cannot stress how important our hospital foundations are to our advancement of technology. So having this wonderful partnership and generous donors at a hospital foundation supporting the work at that local hospital is fantastic. But it's more than that. So for our lab system, anytime a test gets done not very frequently, but is really important, we tend to do it in one place because we want to get good at it. And in order to get good at doing something, you have to do it enough times to get good at it. And so this is a highly specialized test that currently in the province is managed in 2 labs for the entire province. And so Royal Columbian Hospital is actually coming to this as the 3rd lab that will be able to offer this testing. And even though it is taking place at the Royal Columbian Hospital Pathology Department already supports 6 different hospitals throughout Fraser Health already, and all the breast samples coming from those 6 different hospitals as well. So it's not just an impact at the Royal Columbian, it is an impact to many of our hospitals. So any patient who has a biopsy at one of the other hospitals that sends their samples to get processed at the Royal Columbian Hospital, they will also receive the ability to have this test done quickly. But then beyond that, just because it's only at the Royal Columbian Hospital and it isn't covering all of our hospitals, doesn't mean we can't send the samples around. So currently we send our samples outside of Fraser Health to get this test. What having this analyzer within Fraser Health means that not only will we be able to offer it within our Fraser Health system, it will come incorporated on the same pathology report that already exists in Fraser Health. So that it means that for somebody like Dr. Sidhu or Dr. Yu, instead of having to look in 3 places to get all of the information and put it all together, all the information will come together on the first report, which is a fantastic advancement for how we deliver this particular answer. And then on top of all of that, in order to actually make this test work, because it's so specialized, you really need subspecialty expertise. So all of us go to medical school, all of us end up in a residency training for a specific specialty. So pathology for me, surgery for Sue, internal medicine and medical oncology for Dr. Yu. And after that, you can subspecialize even further. So we happen to be very fortunate at the Royal Columbian to have 3 fellowship trained subspecialty breast pathologists who have been able to really delve into this technology, ensure that we are making this test and ensuring that this test works accurately and provides those results. You also need enough technical staff in order to ensure that we can do this validation. In order to make sure this test works correctly, it has taken us hundreds of tests to just get to the point where we're ready to say we're ready to go live. It's hundreds of tests that have to be done before we can even say for sure that it works correctly. And the reason that structure is so rigid and so regulated is because this answer on this specific test makes a big difference. And I think that both Dr. Sidhu and Dr. Yu would attest to that this specific answer on HER2 is a really critical piece of ensuring we are helping the patient move in a direction that is going to be best for their care, should they choose to do that.
That's amazing. I can hear the excitement in your voice, and it's so great to sort of look forward and know that this advancement is right here. And one of the things that I think might be helpful too is to sort of look back at sort of the last decade and how breast cancer care and oncology treatment has changed, say, over the past 10 years. Is that something, Dr. Yu, Dr. Sidhu, that you can each speak to? Give us a glimpse into your world in the last 10 years.
Yeah, I can certainly, I'll start to comment, and yes, I'll let Dr. Sidhu sort of join in, add to it as well. I think for me, so yes, I have been practicing for more than 10 years, so I can comment on this. I think for me, 2 of the biggest developments in breast cancer, particularly early breast cancer, is one, so the better patient selection for chemotherapy. I remember a time when I was practicing, sort of shortly coming out of my training, that we gave a lot of women with early stage breast cancers after their surgery. I gave a lot of women chemotherapy, not really knowing who would best, who would actually benefit or be helped by it. But we kind of did a shotgun approach and said, okay, well, we don't want to miss anybody, so let's give everybody chemotherapy and hope that it helps everyone. We now realize that's not the right approach at all. And there have been sort of important advances in understanding genetics and biology of breast cancer that has allowed us to much better tailor who really needs to have chemotherapy. And I can safely say that we are now giving a lot less chemotherapy than we did 10 years ago for early breast cancer, sparing a lot of women unnecessary toxicity. A second major development, I think, is a transition to using a lot more chemotherapy in the preoperative setting, so before their surgery, which gives us important information, sort of a real-time answer and assessment of how a cancer responds to treatment. And it gives us important information along the way and also at the time of surgery that allow us to perhaps either what we call escalate or de-escalate care. So it allows us to say, okay, treatment has worked really, really well so far. We can cut back on the amount of treatment that's given. The patient's going to do very well. We don't need to continue to give more treatment, versus being able to say somebody hasn't necessarily responded to treatment as well as we would have liked, and giving us the opportunity to then switch strategy or go to a different approach or give a different medication to hopefully improve the outcome. So that transition to treating the cancer with systemic therapy before surgery has been, I would say, a major shift in the overall treatment of breast cancer.
Fantastic. Dr. Sidhu?
Yeah, so that has impacted the way surgeons treat this as well, because as Dr. Yu mentioned, there is an increasing trend towards sending patients to the oncologist for chemotherapy first. And so that requires greater levels of collaboration and more individualized care, rather than, 10 to 20 years ago, almost everybody was getting surgery first, right? And so you didn't have to make that type of extra decision making when meeting with patients. I would say otherwise, there has been a trend towards trying to save women's breasts as much as possible, to try to keep them whole. There's been also a trend towards being able to offer reconstructive options with the plastic surgeons if they are going ahead with a mastectomy or a breast reduction, for example, at the same time. And we've been very fortunate here at Royal Columbian to be able to offer the full gamut of possibilities, being part of the collaborative team that way. There's been also a trend towards less axillary surgery. So that's the armpit. So the armpit we have to enter in order to examine lymph nodes to help give the stage of the breast cancer, which gives the oncologist valuable information. And as time has gone on in the last 10 to 20 years, we've developed surgical techniques that allow us to limit the amount of lymph nodes removed, as well as sometimes not even having to remove any, right? And there's been a definite trend to doing less and less surgery for the armpit, which has also improved long-term outcomes in terms of how women feel afterwards, because those bigger surgeries that we used to do 20 years ago certainly did have long-term implications on how women did in terms of like arm function and swelling and cosmetic results. So there has been a lot of advances, and thankfully at Royal Columbian, we've been on the leading edge of a lot of those over the last 10 years. We've improved the way that we localize these cancers for surgery as well. We are the first hospital in BC to offer something other than wires, which was a traditional method of localizing a cancer inside someone's breast that we couldn't see or feel and could only see it on the imaging. And so women used to have to get these wires sticking out of the breast, and now we've, through collaboration again with all of our different departments with breast imaging and pathology, we've been able to offer another solution where we have seeds that are internally placed instead. That is a lot better for the patient experience as well.
Wow, thank you, both of you. It's truly just so amazing to hear just some of the strides that have been made in cancer care and treatment, and us just moving towards more personalized and effective solutions for our patients is going to make such a huge difference. Thank you. And for the last question from myself, looking ahead, how do you each envision the impact of the HER2 CISH analyzer influencing not only patient care at Royal Columbian Hospital, but also shaping broader trends in cancer diagnostics and treatment? And if you have any stories that you want to tell of, that could help kind of tell this story a little bit more about what you're really excited for, that would be great. And I'll pose that question to each of you. Why don't we start with yourself, Dr. Shiau?
Okay. Well, this analyzer that has arrived at the Columbian is it's a special analyzer because it does this special test, but it can do so many other things too. And so I really appreciate that we've sort of focused on breast cancer and what this analyzer can do for breast cancer. But it's more than just breast cancer. There are so many changes in the way we manage cancer today. And I think we've sort of heard that from Dr. Yu and Dr. Sidhu, that we keep learning. And this is kind of the beauty of medicine, right? We keep learning and we keep studying and we figure out, okay, the way we did it before may not be the best way to do it now. And as we learn those things and as we find better ways to provide a personalized or targeted treatment plan that is like highly specialized for that patient, it becomes more and more important how we select the right patient for that treatment regimen and how we select the right treatment regimen for that patient. And a lot of that can be done in a pathology department that has access to all of these tests. So this is one of many tests that I think can be done within a pathology department if we are able to pool our expertise. So I can foresee a future where this analyzer will be used for more than just this test. It will allow us to do other tests. I don't want to get anybody super excited about it, but we have many other tests in the pipeline that I think will help also expedite care by having that information upfront at the first visit to a specialist. And so that's something that has been outlined quite clearly in the province's 10-year cancer plan. The idea that you should arrive to your first appointment with all the information available to help guide those decisions. And we want to help as part of that. We want to be collaborative with our oncology colleagues to make sure that we are onboarding the tests that they think will help the most and will impact as many patients as we can. It is very hard to do everything. We are all struggling with staffing issues. We are all struggling with the number of patients who need attention and need that time and need that love from us. And we're trying to make sure that we are judicious with how we use those resources so that we can help our staff work to their highest potential, help get answers to as many patients as possible, as quickly as possible. And I foresee more and more things being kind of the trend that we heard, that actually less is better if we can make it targeted. And that I think is a really exciting change in how we manage cancer as we go forward. And I think, again, also a really great example of how this technology, I know we don't all love Teams, but this technology allows us to share our expertise, not just locally, but also, across the province. I may not have an answer, but a colleague of mine in Vancouver Island might. And just this is one of the shining stars of the pandemic, that we all forced ourselves to learn how to use video conferencing so that we could actually talk to each other and collaborate in this manner and find the person who has that expertise. Because with no ego in it at all, it might not be me, right? It might not be me. It might not be my center. It might not be my lab that has this ability, but I want to find the right place for this person's sample and for this person's treatment to take place, and that may be somewhere else. So I want to do the things that can help me to do my best from what resources I have, and then help the patient move forward in their journey. So sorry, that was a long answer. Apologize.
It's all good. Thank you so much. How about over to you, Dr. Sidhu?
Well, I think again, am fortunate to just work at a hospital where there is just such high level of collaboration between not just me and the other breast surgeons I work with, but all of these other specialties. And so we see how that impacts even individual care, but it also has such a huge effect on just being able to always be on that cutting leading edge of whatever the next best thing is in treatment. And so we continue to be actively involved in research at the Columbian. We have some very exciting trials coming up that could change even the way we manage things surgically. And so I am very excited to be part of that team. And I think, there will be a lot of interesting advances coming in the next 10 years that can allow even more tailored surgery, the ability to potentially, remove all the cancer cells at the first operation, for example, that are going to be big game changers for us.
Absolutely. Yes. And Dr. Yu, anything to add?
Yes, thank you.
Okay, I think you're back.
Okay, sorry. Can you guys hear me? I apologize again for technical difficulties. I'll keep my I'll keep my answer a bit short. I'll highlight a case that I recently saw that I was thinking about as I was preparing for this webinar. So I saw a patient recently. She was in her 70s. Like many British Columbians, unfortunately, she doesn't have a family doctor, and she had this growing mass on her breast that she had difficulty getting medical attention for. Eventually, they saw her, arranged for a biopsy. It was on September 19th, and on September 25th, the diagnosis came back as breast cancer, and she had the initial biomarker test done for ER/PR/HER2, and HER2 testing was what we call equivocal on the immunohistochemistry. So she needed the FISH test to properly identify whether she was HER2 positive or not. I ended up seeing the patient on October 12th, so about 2.5 weeks after the breast cancer diagnosis was confirmed. And when I saw her, unfortunately, the FISH test wasn't yet available. So I had a conversation with her and her daughter. All three of us were in the room, and having a diagnosis of breast cancer and discussing the implications is difficult enough, because this was the first appointment where she actually found out she had breast cancer. Making things more complicated is that at the time that I was seeing her, I was missing the information that would allow me to give a definitive treatment plan. Basically, if she were HER2 negative, she would be recommended endocrine therapy, or what we call hormone therapy. And if she were HER2 positive, I would recommend for her to undergo chemotherapy with a targeted agent such as trastuzumab. So unfortunately, with that information not available, we had to put our discussion and treatment plan on hold. And I have to say, I'm sorry, you have to come back, and at the time I brought her back next week with the results then available, and then sort of completing conversation, which to me adds, undue stress to the situation when, patient and family have enough to deal with already. They don't need to have to do this uncertainty as well. And we all recognize that there are bottlenecks in our medical system. We're all dealing with shortages, but I look at this advance and this technology at Royal Columbian as a very, in a way, a quick and simple fix to this problem that is going to just allow us to give that definitive recommendation that much sooner, clarify the treatment plan much sooner for patients and families. So I'm really excited about this, and well, I hope I never have to run into a similar situation again in the future. So yeah, really excited for this development.
Thank you, Dr. Yu. I can hear your heart in that story, and all of you really just the optimism that you see in your work moving forward. So thank you so very, very much for all of your extremely valuable insights. I think that this technology has the potential to inspire some real positive changes in the broader medical community, and it's just really, really exciting to be part of it. So thank you. So everyone, that does take us to the end of our panel discussion. I do want to note that we are planning on spending maybe 10 minutes or so for audience questions. However, I don't see any in them in the chat right now. So go ahead and don't be shy. If you have any questions for any of our experts here today, please go ahead and type those in, and we'll do our best to address them. But before we move into the Q&A, to give you a few minutes to think about those questions, we'd like to show a short video of the analyzer. I think it would be really great to see that analyzer that is located here at Royal Columbian Hospital that is going to impact patients across our region. So let's watch together.
this is our new Ventana Benchmark Ultra, and this is the analyzer that's going to change the way we do breast cancer diagnostics for the province. We've been very generously supported by 2 separate donors, helping us not only fund this equipment, but also some of our consumables cost in order to make sure that we can get this equipment up and running to support all of our patients. I'm so grateful to our hospital foundation and all of our foundations across Fraser Health who come forward to support those extra needs to help make differences that we can't afford to do currently on our own, and the impact that this will have, not just for our patients, but also for our lab staff to feel like we can continue to move ahead. We're short-staffed like everyone else. Everybody's struggling with staffing, everybody's struggling with resources, but knowing that you can make a difference for a patient is, makes it worth it.
So yes, thank you again to our donors. Equipment like this really makes a difference, and it's so tangible and it's attainable. And I'm just truly grateful that RCH is now home to this machine. So we've had a couple of questions that have come in. The first one, I think this would be for yourself, Dr. Sue. Do all breast cancer patients, hold on. I'll go to this one first. How long does someone have to take chemotherapy in order to treat cancer? Who would that be most applicable to?
I don't know if Dr. Yu's still there, and he would usually speak to that, but generally speaking, if a patient is going to get chemotherapy first, I usually am expecting them to get about 6 months of treatment as the typical. And so when I meet patients and I know they're about to get chemotherapy first, I'll often see them, before they start chemotherapy, because there are sometimes some extra tests and stuff that I need for the future surgical planning to be done. And so I still do need to meet them right away. And then I'll typically do a follow-up at about the 3-month mark, halfway through, to see their response to the chemotherapy, to see if they're having any shrinkage, and to kind of go over the surgical options at that point so that we can plan the surgery, which is usually done about a month after the chemo is finished if they're getting chemotherapy first.
Great, thank you. Another comment, thanks for the great talk. Can you comment on the workflow in pathology? Number of cases per year, is technical staff involved, use of scanner and software? Do you reflex test all cases or only immunohistochemistry? 2+.
Wow, that sounds like a pathologist question. Okay. Okay, let me see if I can get all of those things. Okay. So Fraser Health as a whole sees about 1,500 new diagnoses of breast cancer every year. It is a large number. I'm always surprised at that number. All new diagnoses of breast cancer are reflex tested at least for estrogen receptor, progesterone receptor, and HER2. So those are our standard 3 biomarkers, and that is done by immunohistochemistry. The immunohistochemistry is evaluated by a subspecialty breast pathologist at most of our sites, and if it is equivocal, it is then reflexed to ISH testing of some sort. Currently, the ISH testing, of course, done outside of Fraser Health right now, but with this new technology, the ability to do it within Fraser Health is kind of super exciting for us. The ISH testing population in Fraser Health is, let's just say, we're very generous about the ISH testing because this answer is so important. And so if we have any uncertainty at all on the HER2 immunohistochemistry, we will reflex to ISH testing. So at the current time, we are ISH testing approximately 50% of our cases. So that does mean that 1 in 2 breast cancer patients is waiting extra long in order to get this answer. And so that's, I think, that weighs heavily on many of our pathologists. We do have technical staff who work through the immunohistochemistry testing, and we are embarking on a very exciting trial together with the vendor who has provided, who supplies the Benchmark Ultra. That's Roche Ventana. So Roche has a digital slide scanner, which is, again, new cutting edge technology. It actually, they've loaned it to the Royal Columbian Hospital lab for the next 2 months. we're super excited to trial their software. They have a software program that allows us to actually count all of the signals of HER2 in these, and has software support with artificial intelligence also supporting that. This is so cutting edge new that I don't think anyone else in Canada has actually even tried it yet. So we're super excited to trial it. And this is all possible because we have this analyzer and because we've had this breast pathologist specialty expertise in order to validate the test. So from a workflow perspective, this is the difference between spending 2 techs worth of time on this versus a portion of a technologist's time on this, which means I can have that technologist working on so many other things that are so important for the workflow in a pathology lab. So that's a highly technical question. Whoever has that question, you're welcome to contact me directly. I'm happy to talk about this in greater detail. But the idea is that current workflow results in us having to send outside of the region. There's always travel time in that. There's always the risk of loss of the specimen in that travel time. Those are ongoing risks that we sort of manage and mitigate as best as we can, but it happens. Like, we're all human. So being able to do something locally within Fraser Health, again, really helps us support putting all the information in one place, having it all in one place and available for our clinicians, so that people like Dr. Sidhu and Dr. Yu can just, have that first conversation ready. Because I think there's this fantastic hand drawing of a patient cancer journey that was put together by I think BC Patient Safety Quality Council and BC Cancer in collaboration. And the first part of it is that waiting for answers, and just trying to remember that, it's hard to wait for answers. And then when you finally show up, having waited for this answer, to not be able to say, this is what I'm going to do, to come out of your first appointment and go, I'm not sure yet because I'm still waiting, it is really hard. So I think that that's something that I've certainly had lots of friends experience this journey, and try to think about, like, how being able to have all the information to my clinicians early will allow this to allow a patient's journey to proceed as fast as we can manage through our system.
Yeah, great. Thank you for that answer. The next question is, so much progress in the area of breast cancer is so heartwarming, thanks to all the donors. And the question is not about treatment after diagnosis. It's how much is dense breast diagnosis related to breast cancer? Is mammogram and or ultrasound the only way to get a correct diagnosis right now? Thank you.
Well, I guess I'll take that one. A radiologist would be probably the most suited person to answer that, but I know, generally speaking, that the dense breast issue is more of an issue of detecting the breast cancer, and so we rely on mammograms as a screening modality to try to find breast cancer early. When a woman has very dense breasts, then the mammogram is not as useful as it would be should she have more fattier breasts, where then the mammogram is really well suited to pick up small abnormalities. So when a woman does have dense breasts, one question is, do you supplement with some sort of other type of screening modality, such as screening ultrasound? Currently in Canada, we don't have a formal screening ultrasound program. That does exist in some other countries. So that would be something to progress towards, I think, in my opinion, because there is a potential small incremental increase of picking up cases early as a screen detected abnormality, rather than waiting for someone to notice a lump themselves. And so that's the idea behind, dense breast. You do further imaging. So mammograms plus or minus ultrasounds are the standard typically for working up any kind of lesion that you pick up on a screen, or any kind of lump that a woman notices. MRI is the other option in terms of imaging the breasts. It's not something routinely done on most women. The MRI screening program is currently in BC reserved for high-risk women who have like very strong family histories, genetic disorders. There is a program in place in BC currently for them. And then otherwise, it would be used at the discretion of the clinicians, like the doctors involved in that patient's care, on whether it would be helpful in individual cases of women who have come in with breast cancer diagnosis.
Thank you, Dr. Sidhu. And I think this next question might also be for you. Do all breast cancer patients have to have reconstructive plastic surgery when they have their cancer surgery?
So there's different types of surgery we do, right? So we do surgery where we remove either part of a woman's breast or the whole breast, right? So either what's called a partial mastectomy or mastectomy. With a partial mastectomy, I typically don't involve a plastic surgeon, but I do use certain plastic surgery techniques as part of the surgery to be able to close down the defect and shape the breast in a more cosmetic way, hide the incision in more cosmetic locations on the breast. And occasionally we do a much larger partial mastectomy that is more like a breast reduction, which I would then do with a plastic surgeon if the woman was interested in that. And so that's a good option for somebody that maybe say always wanted smaller breasts and now they have a diagnosis of breast cancer and they're basically taking advantage of that opportunity to do bigger surgery to get their breast reduction at the same time. And then I would do that with a plastic surgeon. For women taking off their breast, they don't have to do reconstruction. You know, one option is to do a plain mastectomy and basically be left with no breast on that side. But there is the option for eligible women to get reconstruction at the same time or later on in a delayed manner with a plastic surgeon. And we do offer those options as well with the help of our plastic surgery colleagues. And so these are all options, you know, when women are brought in for their consultation for surgery. Typically we focus, you know, more so on one option versus the other based on the size of the cancer and the person's medical history and what they're hoping to achieve, or potentially discussing all the options at length.
Great, wonderful, thank you. So a few more. I think this one's for you, Dr. Yu. Do patients in Fraser Health participate in new cancer drug trials for new chemotherapy agents?
Let's try this out. Can you guys hear me?
Yeah.
Yes. Okay. All right. Thank you. Yes, there are clinical trials that are run across the Lower Mainland. I would say the majority of them are being done at the BC Cancer Agency site. So within Fraser Health, that would include BC Cancer Surrey and BC Cancer Abbotsford. They would have ongoing clinical trials. I believe Lionsgate Hospital also sometimes run clinical trials as well, maybe not always on breast cancer. So yes, there are clinical trials that are up and running at all these sites. There isn't necessarily a very easily reliable way to access which studies are currently ongoing and what the enrollment criteria are. My advice would be to talk to your oncologist and try to find that information if that is something of interest.
Great, and just one more question for you, Dr. Yu, I believe. What is the difference between hormone treatment and chemotherapy treatment?
So hormone therapy treatment targets the hormone receptors on the breast cancer cells, which are often but not always expressed on the breast cancer cell. So in short, hormone therapy is not necessarily a treatment option for everyone with breast cancer. So one qualifying criteria is that you have to have hormone receptor positive breast cancer for that. And it ends up being a much more targeted therapy in a way. I would say arguably probably one of the very first examples of targeted therapy on oncology would be hormone therapy. Chemotherapy is more sort of less targeted, more general killing of cancer cells, so that regardless of the type of cancer cell that it is. So in a way, it is a potential option for all breast cancers, but we do also know that there are certain breast cancers are much more sensitive or susceptible to chemotherapy versus others. And we take into account those characteristics to help decide whether somebody should or shouldn't receive chemotherapy, looking at the sort of a cost risk benefit ratio analysis.
Great, thank you. Next question is from Deborah. I believe this will be most appropriate for you, Dr. Shiau. The main hospital I am closest to is Abbotsford. How rapidly does testing there get to the Royal Columbian for the utilization of this new equipment? Is it better to go directly to the Royal Columbian, or will my going to the Abbotsford Hospital Cancer Center still give me the same speed in testing? Great question.
That's a fantastic question. So pathology samples, so that first biopsy sample, you need a radiology department that is capable and able to give you that breast imaging to get that sample. And honestly, I would go to the closest place that is the closest to you. And what happens in pathology samples is the pathology sample then moves into the pathology departments, and our pathology department works as a regional team. We move the sample wherever it needs to go to get that testing. So even at current time, let's say if you were to go into the Abbotsford Hospital and have your imaging in the Abbotsford Hospital and a sample taken there, it would be looked at by the pathology department in the Abbotsford Hospital, and it would be sent onwards to the Royal Columbian for specialized HER2 testing, which is actually already how it's happening. So it doesn't change at all how long it takes you to get your result. Our goal in Fraser Health from a pathology department is that everybody have equitable access, no matter what hospital door you walked into, no matter where you had your sample done. We are trying our best to make sure that everyone has equal access to that expertise, that specialized testing. We want to make sure that there should be no change based on where your postal code is. So wherever you can access that care through whatever method, with your mammogram, wherever you get your mammogram, wherever you get your biopsy sample, the testing turnaround time will be the same no matter where. Now, I would preface this by saying this is a new program for us. We're not turning on all of Fraser Health all at once. We're going to start by making sure it works and get all the kinks out by working on it locally. And then as we roll it out, we are anticipating being able to roll it out over the coming year so that we will be able within the year to be able to do everyone's testing with the same wait times, so that those wait times would still be shorter than us having to send it outside of Fraser Health. So that's, I think, very positive for us.
Great answer to a great question. Thank you. And Dr. Shiau, to continue, when doing this is a question from Susan, when doing some of the pathology, some of the specimens are sent to the USA. With this new analyzer, does this help bring more of our pathology testing back home and help expedite results for better patient care? She also went on to say, great talk and wonderful to see the 3 facets of care and the great collaboration within Fraser Health.
Yeah, so that's also a great question. So again, as cancer treatment changes and as we learn more and more things and as we want to look closer and closer at the genetic level, those tests become extremely complex. And we want to make sure that we are offering that testing no matter where. And so right now in the province of British Columbia, we have a coordinated provincial effort to ensure that that specialized, what we call PCR testing or genetic testing, gets done in a way that is equitable, again, and is inclusive of all of the potential targetable genes. So we've actually in BC been able to make some really great strides in ensuring that we can offer all that testing within the province of British Columbia. It's not 100%, but it's getting pretty close. So we are actually sending very few samples across the border to the United States now, which is, I think, also a great advancement. And again, that highly specialized testing needs to be done in a highly specialized lab with the highly specialized personnel. And for the province of BC, that is the BC Cancer Lab in Vancouver, and they do an excellent job. And like every lab, we are all struggling with staffing. So one of the things that I'm excited about is that by Fraser Health being able to take on this testing, we will hopefully be able to free up some of that HR to support more and more of that genetic testing at our centralized provincial lab. I hope one day to be able to do everything that we need to be able to do for Fraser Health patients. But in the interim, the best thing I can do is try to take on what we can in our lab here locally within Fraser Health to support Fraser Health, and that hopefully will also help support the province to be able to move forward on all of that specialized testing.
Great, thank you. Okay, a couple more. It's hard for me to stop this great conversation. We're getting close to the top of the hour, but maybe just two more. Dr. Yu, thoughts on oncotyping for patient-centered care when treating breast cancer?
So I'm going to assume that question is referring to a test called Oncotype DX. Or oncotyping is sort of in general. So I think, in general, the overarching, I guess, answer to the question is we recognize that cancer is a very heterogeneous entity. So one person's breast cancer can be genetically very different from another. So, being able to better genetically classify a breast cancer gives us a lot more insight into the biology of the cancer, what treatments may work, what treatments may not work, and goes back to our goal to having highly personalized patient care, meeting that mantra of the right treatment for the right patient at the right time. I think we all strive for that. And, Oncotype DX is sort of one particular example of that, and one example of genomic testing for breast cancer that, like I said, in the last 10 years or so, have allowed us to significantly cut down the number of patients that we're treating, I would say, unnecessarily with chemotherapy, and sparing a lot of patients unnecessary side effects from treatment. So I think that's one important step forward to this more personalized care. Obviously, lots more needs to be done, and we still have a long way to go. But this is the start of that process.
Great. And the very last question from Heather is for you as well, Dr. Yu. Is chemosensitivity testing done in Canada before treatments?
So chemosensitivity, in the sense that I think there are there are practitioners, I would say, around the world that do what we call in vitro sensitivity to chemotherapy. So, sort of like how if somebody's diagnosed with a bacterial infection, the sample is often tested to see which antibiotic the bacteria would be sensitive to. So that type of in vitro testing, is not routinely available in Canada, and I would say that's not necessarily standard of care as well. I think the idea of it is very attractive. It makes a lot of sense, but I don't think we have that process properly validated to say,
Looks like we may have lost Dr. Yu. Hopefully that answer was as complete as you would have liked, Heather. The next thing I wanted to share is not a question, but it is from our friend Joanne here at RCH. And I just wanted to share that she says the breast imaging and nuclear medicine teams at RCH have been very proud to have worked with Dr. Sidhu and Dr. Shiau to be the first site in BC to offer seed localization procedures. It's wonderful to hear of some of the other amazing work being done. Thank you. And I think that's just such a great way to sum up just some of what we've heard today. And thank you to all three of you for your extremely insightful responses. It's clear that this laboratory equipment is a game changer, and it's going to offer hope and comfort to those who are affected by breast cancer. And, we had over 100 people registered for the webinar today, and I'm just going to be honest that we really felt that it was important to share this advancement through today's webinar when we're thinking about what the topic should be, because it just seems like so many of us are in need of more positive, good news stories right now. So I truly hope that we were able to provide that sense of possibility when we come together with all of our viewers today. Again, it's just deeply grateful to Dr. Shiau, Dr. Sidhu, and Dr. Yu, and our many colleagues across the region for your expertise and your dedication to this work. And thank you to our audience for joining us on this journey today. To learn more about Royal Columbian Hospital Foundation, please visit our website, and please do get in touch if you'd like to learn more about how to get involved with initiatives and needs like the Ventana Benchmark Ultra. We would love to speak with you. So until next time, take good care and bye for now.